welcome to MGFA's Wellness Series webinar, Sleep and MG. My name is Jenna Mbalo, and I'm the Director of Patient Advocacy and Community Engagement at the MGFA, and I'll be moderating today's session. Before we get started, I'd like to go over a few housekeeping items with you. Participants will remain on mute throughout the Zoom call. Please submit your questions via the Zoom Q&A icon located on the Zoom menu bar, and we'll answer them during the Q&A segment. You can submit your comments using the comment icon located at the bottom of the Zoom menu bar. Today's session will be recorded and available online. Now I'd like to give special thanks for the support of our Wellness Series sponsors, Alexion, Argenx, UCB, and Momenta, now a part of the Janssen Pharmaceutical Companies of Johnson & Johnson. We've got a great presentation ahead, and now it's my pleasure to introduce today's speaker, Dr. Urvi Desai. She has been awarded Researcher of the Year and recognized as one of the most influential primary investigators with Neuroscience Clinical Research Division. She has expanded neuromuscular research portfolio in ALS, hereditary, and autoimmune neuromuscular disorders, including MG. She is currently conducting 4 clinical trials in MG and specifically enjoys seeing patients with MG as she feels it is one of the most dynamic and challenging neuromuscular disorders. Dr. Desai is interested in the overlap of neuromuscular disorders and sleep and has devoted time towards investigator-initiated studies addressing the impact of sleep disorders breathing. She has been instrumental in improving standards of care by facilitating early non-invasive ventilation for ALS patients, which is known to improve survival. She is board certified in neurology, neuromuscular medicine, and sleep medicine. Dr. Desai, thank you so much for joining us today. I'll hand it over to you.
Thank you, Gina. I appreciate the invitation. And I'm extremely happy to be part of this wellness series. I think that MGFA is doing wonderful work, educating the members on different areas of how to take care of MG beyond just medications and doctor visits. So I'm very, very happy to be part of this, this series. And again, I want to thank you, MGFA, for inviting me to talk about this topic, which is very, I'm very interested in this. It's quite close to my heart because I know that sleep is one of the most important sleep is the most important aspect of our life. We spend around 122 days a year sleeping. So we definitely want to make sure that we address the sleep disorders, and especially in myasthenic patients, because we know that the weakness that occurs because of the neuromuscular transmission defect is something can also impact the sleep in so many different ways. So the agenda for our today's talk is that we are going to talk about why it is so important to have good sleep, why it is also important to address sleep disorders, specifically in myasthenia gravis. Then we'll delve into the specific sleep disorders in myasthenia, especially including the sleep apnea, hypopnea syndrome, the insomnia spectrum of disorders, and especially restless leg syndrome, which sometimes can be associated with insomnia as well. We will touch base a little bit about the COVID-19 pandemic and its effect on sleep. We'll talk about the good sleep hygiene and also some tips on how to improve your sleep and eventually improve your health. So we all know that when we sleep, we feel better. So sleep has so many different functions to keep us up and going on a daily basis. And it works to repair our cells, our muscles, our organs. During the sleep, we also secrete some hormones which regulate our metabolism, also improve our immune system, which is so important, especially in myasthenia. And it really helps so many key functions for our day-to-day life. The brain also stores new information and memory during sleep, and our memory become more consolidated. So sleep has so many different functions. But unfortunately, we do not have a lot of data of sleep disorders in myasthenia gravis. We just don't know how much lack of sleep or associated sleep disorders affects our myasthenia gravis patients. And because of that, there are not really clear guidelines on how to treat sleep disorders in myasthenia. We know that myasthenia can be associated with significant sense of fatigue and being tired. We know that that can also occur from the sleep disorders. So we really need to understand whether it is fatigue or being tired is from myasthenia or from associated untreated sleep disorders. We also want to understand how medications used in myasthenia disturb our sleep. So we know that steroids, very commonly used prednisone, can cause anxiety, restlessness, and that leads to insomnia. Many patients, when they start high-dose steroids, their sleep becomes extremely fragmented. And the steroids can also cause weight gain, and that leads to, of course, the obesity, and that can lead to the sleep apnea.
Dr. Desai, I'm so sorry to interrupt. I'm just seeing that we can see both of the slides on your presentation.
Okay.
Do you mind resetting the presentation mode?
Okay, let me try again.
Yeah. Perfect.
Is that better?
That's perfect. Thanks so much.
All right, I'm sorry. So we were able to see both the slides, huh?
This is perfect. Thank you.
Okay. So as we were discussing, there is not a lot of data on sleep and in myasthenia, and we really want to delve into what kind of sleep disorders occur in myasthenia. Is it just the sleep apnea or also insomnia, also restless leg syndrome, also hypersomnia, which is excessive daytime sleepiness, and is it because you're just not sleeping well? So I think we want to ask ourselves a very simple screening question. How is my sleep? Do I have difficulty falling asleep? Or do I have difficulty sleeping throughout the night?
Yes.
Do I wake up with dry mouth or sweats? Has anyone ever noticed that I snore loudly or stop breathing in my sleep? And then do I find myself falling asleep during the day when I don't want to? For example, driving, for example, at the wheel, for example, just sitting reading a book and I want to really read that book or watch that TV show, but I just can't keep up and fall asleep. So this is a very simple sleep screen, but it's very important that we do ask these questions to ourselves. And there are some more questions that we can ask ourselves. Do I feel very fatigued and very tired? Or when I wake up in the morning, do I feel refreshed? Or do I feel I want to go back to sleep again? Do I have headaches on waking up in the morning? Do I feel that I sweat a lot during I sleep and I need to change the bed sheets because I sweat so much? Do I wake up frequently for urination, which then causes the sleep disruption, not just related to, for example, prostatic hypertrophy, but for no reason you wake up and have to go to the bathroom frequently? Do I have any acid reflux symptoms and burning sensations in my stomach and throat? Do I toss and turn a lot in sleep? Do I have a lot of excessive movements during sleep? And then do I really have any memory issues? Do I feel like a brain fog? Is my concentration poor? Do I feel anxious? Do I feel depressed? Because so many of these can again be tracked back to poor sleep. And the one most important question we really want to ask is that do we sleep enough? Do we sleep long enough? So the cartoon on the left-hand side shows you at the different ages, these are the recommendation hours of sleep. So babies, for example, can sleep anywhere from 11 to 19 hours. But by the time you're more than 65, your sleep duration goes down anywhere from, let's say, 5 to 9 hours. Although still it is recommended that we sleep around 7 to 8 hours. Now, each one has a different sleep need, so there is some difference, but eventually what we have seen as the time goes on and compared to just a generation ago, Americans sleep 25% less, which is a huge reduction or decrease in the total sleep time. And almost 2/3 of American, when the Sleep Foundation did a poll a few years ago, showed that 2/3 of Americans really do not get enough number of hours of sleep every night. And there was another poll just done in 2020, which showed that people feel so sleepy. So almost half of the people who were polled felt that they feel sleepy around 3 days a week. And almost 30% felt that they feel sleepy around 5 to 7 days a week, which is a huge number. And then we know, as you can see on the right-hand side, that when you do not sleep well, you feel irritable, you have headaches, you just don't feel well. So we know that sleep is very important, and the lack of sleep and excessive sleepiness. I just want to show you that although not each disaster was just related to the sleep disturbance or lack of sleep, but when all this disaster occurred, the time, for example, on your left-hand side, when you see it is the Exxon Valdez disaster occurred at around 11:30 at night. The another cartoon that you see on the left-hand side, which is the Challenger disaster that occurred at around 4 in the morning. The other one you see on the right-hand side is the 3 Mile Island or Chernobyl that also occurred in the middle of the night. And again, there was always this concern, was there associated lack of sleep in operators that led to such disasters. We also see a lot of motor vehicle accidents can be associated with people falling asleep at the wheel or even at the red light. So we want to be very much aware of potential effect of sleep and lack of sleep on everyday life. But in sleep disorders that we can think about in myasthenia, that patients feel as if they cannot sleep. And that could be because they have insomnia or sleep apnea, as you can see, or they feel like they are too sleepy and they either that is because they have sleep apnea, or some patients feel that they have a lot of movements in and around the sleep, which can be associated with restless leg syndrome or occasionally dream acting out behavior type of sleep disorders. So let us focus on sleep apnea hypopnea syndrome, because this is such an important sleep disorder which affects so many patients. And it has been actually described by several studies in myasthenia. So what do we mean when we say apnea? So apnea is a pause in your breathing when you're sleeping. If that happens for more than 10 or 10 seconds, then it is called apnea. The another term is called hypopnea. Hypopnea is a shallow breathing. So when you are sleeping and if your oxygen level drops by 3 to 4% from the previous level, then it is defined as a hypopnea. And when patients have sleep apnea, hypopnea syndrome, they can have recurrent episodes of what we call as apneas and hypopneas throughout the night. And so when we do the sleep study, we look for this number of these episodes, and then we divide by how many hours you slept. So we come up with something called apnea hypopnea index. And if you have 5 or less than 5 episodes per hour, that is kind of normal and physiological. But if you end up having 5 to 15 episodes per hour, that means you have a mild sleep apnea. If you have 16 to 30, we say it is a moderate, and more than 30 is a severe sleep apnea. So what are the risk factors for sleep apnea? Of course, excess weight. We know that when your BMI is more than 25, meaning that you're overweight, or in obese people, when the BMI is more than 30, very commonly is associated with sleep apnea. Also your neck size, shirt neck size. In men, if it is more than 17, and women more than 16, that also increases the chance to have sleep apnea. Some anatomical features. Some patients are born with narrow airways or very large tonsils, large tongue. Some people have very recessed jaw. Those things can also be associated with sleep apnea because it narrows your airway. Age, as we age, there is increased chance of sleep apnea. Sometimes the family history, again, can be related to potentially anatomical features. But the most important factor also is the weak muscles, either in your airways, in your oropharynx, or around your chest wall. For example, like in myasthenia, that neuromuscular weakness is also a very strong risk factor for development of sleep apnea. And especially in myasthenic patients, when we see that when they come in the clinic and when we see that they have abnormal breathing tests during the daytime, or what we call pulmonary function tests, that increases the chance that they would have trouble sleeping and have potential sleep apnea at night. Overnight, if we just do a pulse ox overnight and measure that oxygen level, if it drops below 90%, then we know that there could be increased chance to have sleep apnea. Also, patients who have the weakness, as we just talked about, either of the diaphragm or of the oropharynx, or what we call as a bulbar weakness. And then typically there are two types of apneas that occur. One is called obstructive, and you have narrowing of the airways, and we'll follow in the next slide. We'll see how the narrow airway causes almost stopping in your breathing. But there's also something called central apneas, when as if your brain is telling you not to breathe and there is a pause in the breathing. So I wanted to show you this airway narrowing. So as you can see in the picture on here, can you see my arrow, Jenna?
Yeah, we can.
Awesome. So as you can see here, that as the person is lying down, the air is coming through from the nose, and it is moving through, and it is going through behind the tongue. So this is an open airway, but in the blocked airway, you have this, your palate is just closing the airway completely. It is touching your back of the pharynx, and just as you can see that the air has no way to go through this. And so air passing through narrow airway makes snoring and choking noises, and makes it very difficult for you to breathe. And when that happens repeatedly throughout the night, limiting the air reaching to your lungs, and that makes oxygen to drop. And then your body and your brain becomes oxygen deprived. And this may happen a few times or multiple times in severe cases, as we saw in that apnea and hypopnea index. So when this happens so many times, you wake up numerous times throughout the night, even though you're not conscious of each awakening, and what we call is arousals. And we can see that when we do the sleep study, that every time you have trouble breathing, there is this change in your brain waves, and we see that there is a shift in how the brain waves are kind of going through, and then suddenly, because you can't breathe, there is this arousal, and we clearly see the shift in the sleep studies. You also wake up in the morning feeling very tired. You feel kind of you're not refreshed. You feel very fatigued. You have difficulty concentrating, and then you unintentionally fall asleep. So these are the kind of a physical effect, but there are also a lot of physiological effects, and the risks associated with repeated arousals, what we call, because every time there is a drop in the oxygen level, there is this release of stress hormones. And that leads to increase in the blood pressure, that leads to increase in the heart rate, that leads to increase in the possibility of irregular heartbeats. And that can lead to potentially stroke. If you have diabetes, your diabetes can become worse. Patients develop headaches, and then patients also develop kind of depression, increased mortality because of all these multiple factors. So what are the symptoms that you want to really watch for? For example, you want to see if you snore, or if there are silent pauses in the breathing. Your caretaker is trying to shake you and wake you up when you're sleeping because you have paused in your breathing. You make choking or gasping sounds, and you feel very fatigued during the daytime. You feel like you woke up and you feel like you had not slept. You really want to go back to sleep. You develop morning headaches. You developed frequent nocturia, meaning you want to go back to the bathroom frequently. You have difficulty concentrating. You have a memory loss. You feel very irritable. So when that happens, what do? We do a sleep apnea testing. And so there are two ways to assess this. One is we do the sleep study in the sleep lab, and this cartoon on the right-hand side shows you what to expect when you go to the sleep study. You stay there overnight in the sleep center. It is almost like a hotel room, but you sleep with a lot of sensors hooked up to your body. And what it helps us to see that it keeps us to understand what are your brain waves doing, what is going on with your heart rate, what is going on with your snoring, how loud Do you snore? Are you having any trouble breathing? Are you getting enough air? Are you also through your nose? And are you also having any proper movements of your chest wall? And then also, are there any movement? Are you moving around a lot? Are you kicking your legs? Things like that. There is also something called home sleep apnea test is becoming more common now. We are still very careful in doing home-based sleep studies in patients who have myasthenia because we also want to know if you are having issues with what we call as a hypoventilation, and that is still a bit difficult to pick up on the home sleep study or central apnea, although technology is moving forward and we'll be able to use this technique also in patients with neuromuscular disorders. So there are some unique features of sleep apnea and myasthenia. Typically, in myasthenics, the sleep apnea becomes worse during the REM sleep. And REM sleep is the dream sleep. It is the rapid eye movement sleep. When your tone of your muscles is completely down and you feel you're almost paralyzed except your muscles, we rely a lot on the diaphragm during that time. And so when you have the weakness of the diaphragm, of course, you are not going to breathe well. So both obstructive and central apnea occur, and as I mentioned, the hyperventilation because there is also the weakness of our chest wall muscles. There was a study done in myasthenics to look at the impact of sleep apnea on memory, and they saw that the 60% of the MG patients who did have sleep apnea showed memory problems compared to myasthenic patients who did not have sleep apnea. So you can imagine it was a huge number of MG patients who did have sleep apnea felt that their memory, and they underwent this neuropsychological testing to see how the memory function was there. So of course, as we know that we want to treat this situation because the treatment is not that difficult. So first thing, of course, you want to do the lifestyle change, right? You want to work on the weight loss. You want to avoid any alcohol, quit smoking, and also avoid sleeping on your back because with the gravity, when we are sleeping on your back, the airway becomes more narrow. There are simpler ways like a dental appliance, which can be used in patients who have a milder degree of sleep apnea, where you have kind of a retainer type of dental appliance the dentist would make based on your anatomy of your mouth, and it will help to pull the jaw forward and open the airway. There are also surgical options, many surgical options to treat sleep apnea, which has gone kind of in less favorable situation now because we do have something called PAP or positive airway pressure. And I'm sure you all have heard about the CPAP. So what is the PAP therapy? It is the most effective and the fastest way to treat sleep apnea. It's a machine that uses a stream of air, which gently keeps your airway open. It is like what we call as a pneumatic splint. Typically, there is no oxygen in it. It's just air coming through at a pressure and keeping the airway open, like how we open up the balloon. And this eliminates the breathing pauses because the air keeps the airway open. And so it eliminates the snoring and choking episodes and sleep apnea. So typically there is a mask that you put on your face or your nose or just under the nostril, and that is attached to a hose, and then that hose is attached to a machine. Many CPAP machines come with something called a pressure ramp. So you do not start at a very high pressure. That it would allow you to gradually get accustomed to a low pressure, and then gradually it will increase so that you feel comfortable falling asleep. So there are different kind of PAP therapy. One is called CPAP, which is a continuous positive airway pressure. There's also something called APAP or auto titrating, where the machine kind of delivers the pressure based on your response. We commonly use something called BiPAP in myasthenics, where the pressure device is in a way that when you take the air in, you have a much higher pressure than you exhale out, you breathe out against a lower pressure. And then there are some more advanced therapies called ASV and trilogy that sometimes we have to use in more advanced patients. So I just wanted to show you this type of mask. As you can see, the first one on the left-hand side is the full face mask. The middle one is something called nasal pillows. It just fit under your nostrils, And then this one on the right-hand side is the nasal mask, which is just fits on your nose. So important thing is that no matter what type of mask you use, it is important that it fits well, and there is a good seal and it is comfortable, because if the seal is not good and the air is leaking, there is an intentional leak a little bit, but if there's a lot of air is leaking, then it is very difficult to maintain a good pressure. Now, when people are using the CPAP, there's always this question, is COVID-19 infection? And because you are using the mask, because there is a leakage, could you be exposing your caretakers when you use it if you do have a COVID infection? And potentially, yes, because there is this leak and that would allow the virus to escape. So if something like that is happening, you definitely want to talk to your caretakers and your doctors about that situation. And let's say if you have COVID infection, how to clean and disinfect your PAP machine, mask, accessories, of course, with soap and water. And typically you can do once a week, but some people would do every 3 days or even on a daily basis. But you just don't want to focus on cleaning the machine. You want to improve also other hygiene measures like disinfecting and washing your hands and other measures, including wearing the mask otherwise when you're not using the machine, for example. So I'm going to change the topic here and talk about insomnia, because we also know that this is another disorder of sleep, which affects a lot of patients, but it also affects myasthenic patients a lot. So there was a study done which showed that what was the incidence and correlations of depression, anxiety, and insomnia in myasthenia. And what they found is that close to 40% of myasthenic patients had insomnia, which is a much higher number than we see in general population. Depression was as high as 60%, and anxiety was as high as 45%. So, we definitely do not want to underestimate this coexisting conditions that can eventually make the myasthenia and control of myasthenia worse. So, what are the causes of insomnia, especially in myasthenia? There are a lot of causes, of course, of insomnia, but specifically if we look at myasthenia as we age, of course, older age myasthenics have more common insomnia than the younger age myasthenics, and also the severity of myasthenia. If you're more severe disease, there's a chance that you would have more insomnia, and also patients who are going through the crisis. And in the hospital settings, that is also not uncommon to have significant insomnia. Feeling short of breath is very anxiety provoking. And while you're feeling short of breath, it is, of course, very difficult to sleep. But we also use medications like steroids, right? Which, as we saw in the beginning, is that have a potential to feel very irritable. And then, of course, psychiatric comorbidities. But we also want to understand that with recent COVID-19 pandemic, there has been significant concern regarding insomnia and what is related to that. I have just put a list of the different medications that are used in insomnia, to treat insomnia, to make you fall asleep, but potentially could have some effect on myasthenia. And again, this is only a single study which had looked at this. As I was saying, there's not a whole lot of research, but maybe this is helpful when your doctor is putting you on medications for insomnia to talk about potential effect on your myasthenia. So is COVID-19 keeping you up at night? And you're not alone in that. There is a new term now, people say it's COVID-somnia. And but this insomnia related to COVID can be brought on by many factors, including fears about the coronavirus, the concern for your loved ones and for your own self, economic worries, limited social contact, feeling isolated, and that all leading to increased stress and anxiety. There's also an uptick in the screen time. We spend a lot of time on different kind of screens, maybe phone or tablets, or laptops or computers or TV. And there is some lack of exercise, which is also contributing to insomnia and keeping up awake related to COVID-19. So what you can do, There are a lot of behavioral things that we can do to make sure that we have a really good sleep habit and sleep hygiene. So you really want to establish a very regular sleep schedule. You want to go to bed only when you are sleepy, not just fatigued, but really sleepy. And get out of bed if you cannot fall asleep after trying for 20 to 30 minutes. Then you want to go to the other room where it is very quiet, no noise, and do not want to again engage into any activities which is very much causing anxiety, or looking at a bright screen of phone or iPad, for example. You want to wake up at a regular time every morning, regardless of sleep time. And gradually, once you do that and expose yourself to early morning light, you would be able to fall asleep better at night. And then you also want to avoid very lengthy or late naps, because sleeping during the daytime can interfere with the sleep at night. So the good thing is to create a very good bedtime routine. You want to engage in a very relaxing and non-alerting activity. You do not want to drink or eat too much close to your bedtime. You want to avoid any caffeinated beverages. I tell my patients not to drink anything with caffeine after 2 or 3 p.m. because caffeine has a very long half-life and has a tendency to keep you awake. You also want to avoid smoking, especially closer to bedtime, but absolutely avoid it. And also alcohol, because alcohol has a tendency to disrupt your sleep pretty significantly. The bedroom is to sleep, and so you do not want to eat, watch TV, listen to the radio, plan something, problem solving, all those things in your bedroom. Use it mainly for sleep. And exercise as your MG allows, but then do not exercise very close to the bedtime. Maintain a very quiet and dark and comfortable sleep environment. And especially turn off all your electronic devices 30 to 60 minutes before the bedtime. There was also this question I wanted to address when I talked to Jenna about the COVID vaccination, because you all are at this stage, I'm sure, quite aware of this COVID-19 vaccination and how it can affect myasthenia. But we also want to talk about how healthy sleep and COVID vaccination has some correlation. So we know that healthy sleep is very essential for a strong immune system. And sleep loss is linked to changes in immune responses. So if you don't sleep well, our immune responses are blunted, and they do not mount a good immune response if you get the vaccination. And poor sleep thus can weaken the defenses against a virus. So there have been some studies which have shown that there is a relationship between sleep duration and vaccination. So there was a 2020 study that was done which showed that patients who received the flu vaccine, the vaccination was more effective in people who got really good sleep 2 nights before they received the shot. So if you're planning to get the COVID vaccine, then I would suggest that make sure that you address your sleep and sleep well, not just the 2 nights before, but continue to engage into really good sleep habits. And I want to touch base just a little bit about how technology is hurting our sleep. You know, we are seeing that our bedrooms are getting smarter, but are they really getting smarter? There are so many gadgets that have entered into our bedrooms, like apps. There are wearables, trackers, there are smart mattresses, there are headbands, and they all claim to measure your brain activity. They claim that they are going to monitor your sleep, and also promise that you're going to fall asleep much better, or you will stay asleep, or your sleep will get better. But we don't know how really they can help to solve your sleep problems. And there is overall lack of data and validity and accuracy and reliability of all these gadgets. So be very careful. So I feel like it is very important to focus on how you feel when you wake up in the morning, rather than your Fitbit or your Apple Watch telling you how you slept the night before. Because it can have some unintended side effects. And if there is kind of not a good correlation between how you feel and what the data is telling you, then it can reinforce poor sleep habits and make your insomnia actually even worse, and you make you more anxious that, oh, my tracker is telling me I'm not sleeping well. So just not overly be reliant on these trackers, and just don't diagnose sleep disorders based on and do not replace proper sleep evaluation by your sleep doctor and testing in the sleep lab, or even at some point home sleep testing if appropriate, which is FDA approved, reliable, and your doctors can review them and interpret those studies rather than relying on these technologies. But we know that there is improvement in the technology, and some technologies can help sleep better. So there are some apps which track your snoring. And if you are sleeping alone, you don't know whether you are snoring or not. This could be a good way to see if indeed there is some snoring going on, so that you can talk to your doctor. It can help to adjust your sleep schedule, especially when you're traveling, like a jet lag situation. Um, some apps have a guided meditation that can help you ease into sleep. We know that there is a role of integrative medicine, mindful-based stress reduction, which can definitely help to improve the sleep, consolidation, and insomnia. And there are apps to help you with that. And there are some wearable technologies that we use in restless leg syndrome, which can also give some information that how we can improve those symptoms. But we want to understand that just simply tracking the sleep doesn't really improve it. So we want to consider this technology, how to improve your healthy sleep behavior and habits, and not just as a fast fix to the sleep problems. Very briefly, I'll touch base on restless leg, because the restless leg syndrome, there have been some studies done in myasthenia, and I'm interested in this topic because it also can contribute to insomnia, either difficulty falling asleep, or if the restless leg syndromes are associated with something called periodic limb movements, meaning you are kicking your legs at night, then continuing to maintain your sleep once you fall asleep. So one study showed that almost 43% of myasthenics had restless leg syndrome compared to 20% control in that sleep study. And then another study looked at which showed that almost 40% of myasthenics had moderate to severe restless leg syndrome, which affected their quality of life. So again, there is not a lot of literature. Actually, I was not able to find more than these two studies which were robust regarding looking at the restless leg syndrome. But this is interesting to see that almost more than double than control myasthenic patients had these symptoms. So just what are the key symptoms of restless leg syndrome? That there is a strong urge to move your legs with unpleasant sensations. They usually occur when you are inactive, so when you are resting, when you are lying down, and there is this strong diurnal component, meaning that symptoms predominantly occur in the evenings or when you're trying to fall asleep at night. And then the relief occurs because of the movement. So sometimes patient would get up and walk around. Sometimes I have some patients who have such a bad restless leg that they have a bike next to their bed and they will get on that. So these are the four main symptoms of restless leg syndrome. But it is very difficult for a lot of patients to describe what sensations that they are feeling in their feet or in their legs. If there are creeping, crawly sensations, if they're itching, if they're burning, if there are kind of, some people have given so many different ways. And sometimes patients say, well, we can't describe what the sensations are. I had one patient who described it very well and said, my legs get busy and try to fall asleep or sit down. So restless leg syndrome is definitely something to keep in mind because that, as I said, can be associated with sleep apnea. Again, we just don't have a lot of literature to tell us the scope of the problem, but whatever few studies have shown that there could be a possibility. So I just want to close the talk with this cartoon from the National Sleep Foundation, that there are some helpful tips that can help you sleep better. And we talked a lot about that, but this is just kind of consolidates into sleep, starting with as is a structure. So you really want to create a good routine structure regarding your schedule of sleep. Then L is the light. You want to expose to a bright light in the morning and not so bright light when you try to fall asleep. Electronics, avoid electronics as we discussed in detail. Exercise, and again, exercise, this cannot be applied to all myasthenia patients. You have to be careful and you have to see what you can do. Of course, you don't want to overexert yourself. So this is something you want to talk in context of your disease and with advice of your doctors, and then prioritize. That sleep is so important, as we just reviewed so many factors about sleep, and sleep is something that is going to keep us healthy going forward. So we definitely want to have excellent sleep habits and understand the importance of sleep in our life. The last but not the least is that Shakespeare has described sleep in so wonderful way. But basically, eventually he says that sleep is the chief nourisher in the life's feast. So I'll stop here, but I'm very happy to take any questions if you have.
Thank you so much. We do have a couple questions. So the first one is, did the study showing memory problems in MG patients with sleep apnea look only at untreated sleep apnea, or did it also show memory effects in patients whose apnea is treated?
Now, that's a great question. They typically looked at patients who were not treated. So these are the patients who had symptoms but no treatment for sleep apnea.
Okay. What are signs to distinguish when a patient needs a CPAP versus a BPAP? I already successfully used the CPAP, but continue to experience symptoms like dry mouth, exhaustion, and waking in the middle of the night.
Right. So your sleep, you want to talk to your sleep doctor and review your sleep study to see whether whether it is appropriate for you to switch from CPAP to BiPAP. The sleep study would give some indications, and that is one thing. The second thing is also that your doctor can download the information from your CPAP machine, which gives them a lot of information about, how many hours you are sleeping, how many hours of that you're sleeping for more than 4 hours, because that is something required for the insurance approval. The download also gives information about how many times you're still having apnea and hypopnea every hour. It also gives indication of how many times you're having central apnea. It also gives information about what is the leakage. And so based on that download, the doctor can definitely look into if, and then on top of that, with the myasthenia, they also want to make sure what is going on with the chest wall weakness and your diaphragmatic weakness. So definitely talk to your sleep doctor to address that.
Thank you. What if you are already treated for sleep apnea with a CPAP, but still experience symptoms? Oh, I'm sorry, that one was just answered. Okay. How does insomnia that involves multiple awakenings where you can go back to sleep immediately differ from insomnia where you wake up and can't get back to sleep? How is it treated?
So we definitely want to first find out why you are waking up so frequently. Is it because of any sleep disorder, or because you have to go to the bathroom frequently, or it is just what we call as a spontaneous arousals when we don't know, or sometimes those leg movements that are waking you up. So there are so many different reasons. There's no specific difference between, how you treat, whether you can get back to sleep immediately. I think if you can get back to sleep immediately, then just addressing what are the factors waking you up could take care of it, versus patients who wake up but then just cannot go back to sleep.
Thank you. What are the devices that can be used for RLS?
So I cannot share that because there is nothing FDA approved at the moment, but this is the technology that we are going to get through as the time comes forward. And again, there are so many different apps and technologies are being developed, which some are good, and we really want to focus on that. But then we also want to be very careful of what is good and what is not so good.
Thanks. Okay, this next question is, can small regular doses of prednisone affect sleep? 10 milligrams every other day.
So I cannot speak directly or exactly based on the dose. but we know that the prednisone does have impact on sleep. And some patients are sensitive to even lower doses of prednisone, that they become irritable, they develop insomnia, some at a higher doses also develop something called stereopsychosis. So it really depends on the individual, but it is difficult to say whether it is just the dose which will cause the insomnia, because some patients even at a higher dose do okay. So it really depends on an individual how the steroid is going to affect them.
Okay. Does melatonin help with falling asleep with MG?
So melatonin can help, but if you look back to that little chart that I showed you, there were occasional case reports, could there be any myasthenia exacerbation? I did not find that significantly in the literature. So that's why I said there was just a single study, but I wanted to share that. So just to make you aware, but I personally have not seen it. And I think that melatonin is probably one of the safest thing to consider when you start thinking about treating your insomnia, again, in the collaboration with your doctor.
Okay. What are the 4 clinical trials that you're working on?
So there is one trial which is by Alexion, which is a trial of a long-acting complement inhibitor. There is another trial by Takeda that we are looking at, and then another trial by the Viela Bio. These are the trials which are looking at specific type of cells called CD19 and CD38. There is another trial which is from UCB. We are working on if we can use a new technique instead of IVIG to treat these patients called FcRn inhibitors. So there is a lot of research going on. This is a very exciting time to be in neuromuscular medicine, especially addressing myasthenia. And I know as patients, yes, it is exciting time, but you also are going through so many challenges. So hopefully we will have some better data that would come out from these different trials. But these are what we are looking at the moment.
Yeah, that's really exciting that there's so many going on right now.
That is right.
Regarding naps, what do you consider too long? What's a good amount of time to get some relief, but not mess up your night's sleep?
I think that's a great question. I would say around 20 to 30 minutes. If it goes beyond that, I think probably it will interfere with the sleep.
Okay. How do you find a MG sleep doctor? I can't seem to find one in the Boston area that has MG or APNEA experience. Is there a registry?
Great question. Maybe MGFA can start looking into that and trying to see if we can do a survey to see if there are physicians who are interested in both MG and sleep. There are not, if that's the question, right? Finding a physician, yeah. There are not many neuromuscular specialists who are also interested or have training and board certification in sleep. There are a few of us, but I think that the overlap is so strong that there is more and more interest. Even with our ANEM, which is a main body where we all come together, neuromuscular doctors. Gradually, if you will see the programs, there is increasing awareness of sleep disorders in neuromuscular, which wasn't there around 10, 15 years ago. So I think that there's a lot of awareness, there is a lot of interest. And so we will be able to see this combination, or at least the interest to address these sleep disorders in neuromuscular and MG patients. But that is something we should think about looking and doing survey of our doctors.
Yeah, I think even to start with some of our partners in care, that would be a great place.
Yeah, I think that's a great point. Yes, absolutely.
Can you clarify the sleep medication issues with MG?
So again, for example, if somebody is going to consider benzo, right? These are the benzodiazepines, which do have a potential to cause respiratory suppression. So that can kind of, impact your breathing. And if you do have sleep apnea, if you have myasthenia, which is not controlled well, and you have weakness from that, I think that is not a good idea to consider those type of medications. We talked about steroids, and I talk about it all the time because I have seen patients having significant insomnia symptoms from steroids and how it complicates the situation. So there are medications we could use, but we just want to be very, very careful when we choose those medications. And as a neuromuscular specialist, whenever we see patients and we see their medication list, and we see that they're going to be starting on a new medicine or something, we always go back to MGFA has a wonderful list of all the medications to be careful about. And we even as a physicians go back to that list and share with our patients. So I think that is always something to even make your doctor aware if they don't know, but keep that with you as well.
Yeah, thanks. That cautionary drug list is really a helpful resource.
Yeah. Mm-hmm.
Okay, are there effective medications for RLS?
There are many effective medications for RLS, and I didn't go in more detail because I had no idea how much time Jenna was going to give me. But one thing, so I'll touch base on that at the moment because I think it is a very, very great question. We always check for iron in those patients because iron deficiency is associated with restless leg syndrome. So if you're iron deficient, then that is something we treat with iron, over-the-counter iron, or and ask the patients to take the iron with vitamin C, which improves the absorption. So depending, we check something called ferritin, which is an iron-binding protein, and then helps us to understand what is your iron level. And if it is less than 50, we treat. Even now, recommendation is if it is less than 75, then we start treating with iron supplementation. So that is one very easy thing we can do. But there are medications, so like medications like gabapentin or pregabalin can be used. They are actually approved for restless leg syndrome. And then there is a whole group of medications called dopamine agonist. These are the medicines that are used in Parkinson's disease. But we use at a very, very low dose for restless leg compared to the Parkinson's disease. These are so at a very low dose, these medications are extremely helpful for patients. Very rarely, when restless leg is so severe, we can use opiates, but we have much better medications than that. And sometimes you can use clonazepam to help those patients as well.
Thank you. Can you healthily divide your 7 to 8 hours into 2 chunks with some awake time in between, like sleep 3 hours, read for 1.5, and then sleep 4 more?
I love those questions. They're wonderful. So I would say no. And the reason is that when we sleep, we go through these different sleep cycles. So after initial, you typically fall asleep within typically what we call is a sleep latency. So how long it takes you to fall asleep. Let's say 20 to 30 minutes. I would say 20 minutes is better. And then you get around 90 minutes or after that, you get into something called dream sleep. And then as the time goes on, gradually your dream sleeps become more frequent and longer lasting. And the dream sleep or a REM sleep or rapid eye movement and the non-REM sleep, which is divided into sleep stages of 1, 2, and 3. 3 is the deep level of sleep. They all have very specific functions. So, like for example, some hormones are secreted in what we call as a non-REM deep sleep, especially in children, the growth hormone, for example. That's why the children have really a huge amount of stage 3, which is a deep sleep. But there is a memory that concentration occurs in the REM sleep or a dream sleep. So if you sleep and you fragment, then you are not getting into that routine cycle, which is very important for us for the physiological function. So not a good idea.
Okay, that's good to know. How do we explain to our neurologists that we have RLS and think it's part of our MG when they disagree?
As I said, there are not many, there's not a lot of research, but there are these two trials. And I have put those information about those studies. Maybe you can share with your doctor and say, well, there was some study done which showed these results. But you can just, even if it is with or without MG, it is indeed an entity and indeed a disorder. So irrespective of MG, it ought to be treated to improve your sleep if you really have the restless leg syndrome, because it can lead to insomnia. It can cause sleep disruption. If 30% of those patients could have something called periodic limb movement, which then there is intermittent movement of your legs happening throughout the night, and then it can disturb the sleep as well. So yeah, talk to them. Yes, it is very early in the research, but hopefully we'll know more.
Thank you. Can lack of deep sleep cause consistent eye twitching?
I don't think so. I'm not aware of that correlation.
This next one is, I have heard that some neurologists order a sleep study as part of the MG workup. Is that something that should be done regularly?
I think that I'm not sure regularly is a good way to do it, but I definitely would say that you want to have a very big antenna and very low threshold of ordering sleep study in our myasthenic patients based on what we saw. So I don't think there's anything regular in medicine, because we definitely want to apply what is the right thing to do based on patient symptoms. But I would say that that is something to keep a very close watch on, and if there are any symptoms, consider that.
Okay. Okay, this question is, my insurance will not cover a trilogy unless I have a trach, which is what my doctor is trying to avoid, but they will approve a BPAP with AVAPS. What's the difference, and will the BiPAP versus AVAPS be enough for me?
So it really depends, and that's a great question. So the BiPAP with AVAPS has a slightly different methodology compared to the trilogy, which supports a volume and a pressure, both when you breathe. It really depends on your breathing, and I would suggest that you talk to your lung doctor and see and go into really details of your of what we call as a pulmonary function test, in addition to what is happening overnight with the sleep study, and that combination potentially could help to get the trilogy. We are able to get trilogy, especially in our ALS patients, and we needed to see some guidelines. We had those guidelines, but they have been a little bit, I would say, made a little bit easier during COVID-19, just because we cannot get the PFT as easily, because of, it will cause aerosolization and potentially increase the risk of COVID infection transmission. So talk to your doctor and see if they can get all this data together and get you approved.
Thank you. It's really helpful. Well, we're at the hour now, and we've answered all of the questions. Thank you, everyone, for submitting your questions. Thank you, Dr. Desai, for a wonderful presentation and for teaching us all about sleep and MG, especially the COVID-somnia. I thought that was a really interesting new term that seems very relevant right now. MGFA will be hosting these webinars throughout the rest of the year. Please be on the lookout for more updates. Thanks, everyone, and enjoy the rest of your day.
Thank you. Thanks for the invitation. I really enjoyed it. Thank you.
Thank you. Bye.
Bye.